Okay, let's begin. So we haven't had lab meeting for last, I think maybe 3 weeks or something. I've been traveling. I was like in transit on mostly Tuesday. So all right. Richard, are you able to give us update or are you busy? Okay, let's do Eugene after Eugene first because
Okay.
you're in
Yes.
Korea.
Yes. Good morning, everyone. I finally, came back, and I just want to update about two projects mainly.
Mm-hmm.
For first one is about hyperprogression.
Uh-huh.
I think Dr. Jian also has something to update us regarding this project, but
Huh?
let me just briefly share about the key results that I've um found through a reanalysis of the data.
Okay.
And can everyone see the screen?
Yeah.
Okay. So thanks to the all the lab members who recollected the data about metastasis, I I was able to run all the survival analysis and then also for the risk factor analysis again. And for the survival analysis, main results are not changing. But then so Dr. Shea, I just want to make it clear that you want us to put only the results from original definition, right? Not from the modified definition, right?
Right, right. That's modified is just for suggestion at the later. Yeah.
Okay, okay. So for the Champia, just just to update you guys, like these are the survivor curve for from original definition. When you compared it with the like new means modified one, um, you can notice like for Champia,
Mm-hmm.
there are not that much. Both definitions were producing significant like results in terms of progression for survivor. And just please see the left side graph, not right side. So these are the main result, and these are the main result. It and the graphs are look like a little bit different, but then statistical significance are remaining. Is remained here like this. And for the Cox analysis, Dr. Shai, I want us to fix which model are we gonna present. So I try to include some like important characteristics like a diagnosis age and stage, um, female or male, line, line of treatment, and ECOG status. And I just want to explore whether like all the metastasis burden, whether there will be some factors or variables that show significant results in terms of metastasis burden, but none of them were shown to have some significant results. Only here you can see only female or male, and then ECOG stage were statistically significant factors in terms of predicting progression for survivor. So I might just go with this first model, including just 5 variables.
Why
Is
is
that
that? Why are you choosing that?
these are These are factors that are considered to be associated with, like disease burden and progression-free survivor. I actually didn't like have any not much like references that I chose this based on I chose this specific variables, but do I have to include more or another variables?
So this is univariate,
This is multivariate analysis.
but did you do univariate for each variable?
Oh, for each variables, I didn't do that.
So before you do multivariate, you have to do univariate for each variable to show, what is the impact of each variables.
Okay, and then based on the results, I can pick up some variables to include in multi-analysis. Okay, then because we collected so many variables in terms of, variables that can be included in the univariable
So
analysis
all the variables that you have to do univariate for all.
for all. Okay.
And
Okay, and
for the variables that seems to have impact, you could do multivariate.
only including those.
Yeah,
or
that's one way to do it. There's a different way to do it.
okay.
Adding one each at a time or deleting one each at a time and see what the effect is. Minjung has done it before. Talk to Minjung.
Okay. I see. For the okay, for like for univariate and then multivariate.
Yeah. And how did you put line? Did you put one first line, second line? Do you have third, fourth line?
So I made for variables depending on the classification of line. So line 2 means line 1 I only included line 1 first and second line, and I classified above third line as another group. So I just try out many different definition of line. If you see here, like line 2 to line 2, 3, it all has different like classification, but because there are first line, second line, and third and above. So
best way is first line versus all the other lines. Because if you categorize in 3 different ways, it doesn't have the same weight. It's not 1, 2, 3.
Yes. So I think I made that. I think line 2 is based on your suggestion, like the first and then all the other lines. But none of line classification were detected as significantly correlated with the progression-free survivor, at least in the multivariate analysis. But yeah, I'll do the univariate as well.
And monotherapy versus combo. Where's that?
Yeah, I remember we collected that information. I think I missed that. I will include that as well. So
ICI mono, you can have. Did anyone receive Nivo-IPI?
There are some who received Nivo-IPI. Actually, regimen, it's coded as a regimen. I think I missed for this, but there are, so based on our data collection, we were able to classify all the regimen into 7 categories. And then there were some Nivo-IPI.
So when
There
I
were
say
some people.
combination,
Mhm.
it's strictly referring to combination of chemo and immuno. So immuno
see.
only should include nivo-ipi.
I see. I understood.
So it's chemo immuno versus immuno only. So that is going to be a significant very I think dividing factor.
Okay. Okay, I see. Then I think all the other results are just a little bit meaningless because I didn't do univariate before the multivariate. So
It's okay, just show me what you have. So
okay.
higher level of what leads to higher risk of hyperprogression? Higher number of ECOG performance status?
But Dr. Che, like I think I did the progression-free survival analysis with the outcome of real progression, not just hyperprogression.
Oh,
So
so it's just the progression. Okay.
yes, if you see the formula, the outcome is progression, real progression, and then there is a factor of hyperprogression in the explanatory variables.
I don't understand.
So for survivor analysis, our outcome was not the hyperprogression, but the real like progression and then death.
I see. So this is still hyperprogression paper. Okay. So
For
this
hyper, yes.
let me tell you this. For Cox regression, you
Mhm.
have time to event analysis. So the outcome is PFS or OS.
Yes.
Now, when you have hyperprogression, then you're likely to have worse PFS or OS. Correct?
Yes. Yes.
Then you could see,
Yes. We can.
and it doesn't matter what definition you use, Champion
Correct.
or revised definition. Okay.
For PFS, I think all definition, whether it is original or modified one, indicate worse. I was correlated with worse progression for survivor, but then for OS over survivor, there were some difference. Like all original definition were correlated with worse over survivor, but then modified one only Sadabuzid maybe was correlated. Let me just. I'm sorry, I didn't make it very presentable, but because of there are so many results. But let me just share only survival graph so that you can get a grasp of the whole picture.
I think it was a Ferrara.
Ferrara, maybe, yeah. That's okay. Let me briefly share another document. I think. Can you see the screen?
Mm-hmm.
Can you see the figure?
Mm-hmm.
Yes. So here you can see the progression-free survival result and overall survival on the right side. And then Champia, Sadabuzid. And I also, okay, so let's talk about the original version first. So if you see the like p-value, both Champia and Sadabuzid original definition were correlated with worse outcome. progression-free survivor and overall survivor. But when we used a modified definition, you know, the real correlation between the definition and the hyperprogression and the progression-free survival was preserved. But then for overall survivor, unfortunately, I think the strength was weakened a little bit. So Champia, the p-value was not even closer to the marginal one. For Sadabuzid, it was marginal, I think we can say that. And for Ferrara, interestingly, Ferrara, only for Ferrara definition, we were able to detect patients with hyperprogression only with the modified version for Ferrara definition. But that in that case, hyperprogression was correlated with both worse FS and WIS. So my guess is, as we discussed earlier in Dr. Shi, I think for modified one, some definition might include pseudo hyperprogression patients as well, you know, by modifying the definition. So maybe that could impact on this survival analysis.
So let's look at the hyperprogression positive numbers at the baseline. Champion is 7.
Sadabuzid 14. And
Okay.
Ferrara,
And then how does the change in the modified version?
in the modified one, Champia 16, Sadabuzid 21, and Ferrara 9, maybe 8.
So-
I think it's a kind of error here. 8 were included, but here 9. My guess is originally it was 9, but maybe I have to check why it's 8.
So compare each definition, original versus modified.
Yes,
So Champia was 7 and it goes to what?
16.
7 to 16.
I think we made it in a nice table. We made it as a nice table in our abstract submitted for CC. You want me to show that, or
No, I think I said I want like like a graph or pie chart or something to show how, modified definition changes the inclusion of hyperprogression.
yeah, I think Dr. Jian has. You remember we actually when for the abstract for CC, we actually visualized all the patients' 3 time points tumor burden to show which patients are detected using modified definition. So we have a graph for that actually. I think Dr. Jiang can present that later.
Okay, so let's see. Champion is 7 to 16. What was that?
Yes, 16.
Okay. And what about Sadabuzid? What happened?
14 to 21.
14 to 21. Still such a small number. What about Ferrara?
Ferrara original one did not detect any hyperprogression, but then for modified one, we were able to detect, I think 9, yes. But
Why is there a difference OSPF numbers?
I noticed that. So my guess is, the difference of numbers is small, but still, I think some maybe some patients' data I think I have to recheck the data. In terms of, but at least when I just look over all the data set, there were not missing data in terms of very important variables like death or alive, something like that. But I'll double check about the number difference.
Okay. Yeah, I don't understand why there's a difference. 127, 113, 16, 15.
Mm. Oh, I see. I can explain it. Actually, Dr. Che, we use different data set for PFS and OS actually.
Oh, why?
Because remember when I asked about, you remember we decided to include each regimen for progression-free survival analysis because patient can progress on each different regimen. But
Mm,
then for overall survivor, you told us that we will include only single, like we will not include the multiple regimen the patient received so far. So we just had to, yeah, that's the reason why they're different.
I get it.
Yeah, so there are two different Excel file, including all the regimen and with only single regimen per each patient. So I use different data analysis, data set for this.
Yeah, that makes sense. So you have to explain that in detail in method.
Okay. So yeah, if you look at the total number, in total, we included only 128 patients.
Mm.
But when we consider multiple regimen of immunotherapy that patient received, there are 143.
Makes sense. Makes sense. So I think you can just show original definition. You don't have to show modified.
Oh.
So modified, so your hypothesis that it might be catching more pseudo progression.
Yes. I mean, I guess I can explain that modified one can actually capture real hyperprogression patients better, but then it was not that fine-tuned, so it ended up catching a few not true hyperprogression, but like pseudo hyperprogression patients, so leading the correlation between outcome less stronger, maybe.
Hmm. Hmm. Yeah, it's tricky. It's really tricky. So maybe I guess the best modified, in that case, the best modified hyperprogression, you not
Definition.
only need 3 time points, but you might need another time point
Yes,
to get rid
true.
of pseudo progressions, right?
Right. If we can actually look at that and then compare each patient to actually delete the pseudo hyperprogression patient, then our results, or maybe there is something we can talk, I mean more meaningful.
Actually, Dr. Che, I feel for the pseudo hyperprogressions that you talk about another time point, I feel like that's like the way that we can suggest the new RECIST criteria, because RECIST 1 only 101, the IRSs, they have like 2 times point after the best twice to exclude pseudo hyperprogression or like pseudo like the progress for the IRSs, but again they didn't add the new target lesions if it's IRSs. So I think that can become a suggestion for our paper about the 2 timeline, but including the new target lesions. I think that's kind of suggestion.
Mm.
Makes sense.
You know, maybe in our paper, is there, I know it's gonna be a lot of work, but is there a way to see who has one more CT scan but in order to know who is pseudo hyperprogression, the assumption is they should not change their
Mm,
treatment regimen. They should remain on it so that the hyperprogression, you know, some will regress but if you change regimen, then you can evaluate that.
It's kind of tricky because it means we need to recheck the epic again, like one by one for our hyperprogression patients, and whether they have the same regimen or not. If they have the same regimen, then we can recheck whether it's pseudo or not. Yeah.
So it's only 14 patients, right?
How much is it, Eugene? 14 or more?
for modified one, 21 at the maximum for Sarabusit.
We only take the Sadabusit or we also take the other one, Dr. Che?
I think we have to see all the different.
Yeah, I think. Well, didn't we decide? Well, I guess we're gonna suggest Champiad is better. Didn't we say? Right, Champiad is better.
Yes, yeah. Champia,
So let's just pick one because we can't do too many. Champiad and modified Champiad. Let's just use 2 and look at the epic notes. See if any one of them continued therapy until the next scan. If there's none, that's fine. We just say we look to see if anyone had pseudo progression. And that requires, you know, continuing the same therapy. But in our cohort, none of them, you know, was eligible, or one was eligible, and that patient actually did have increased resist or something, or was actually confirmed to be pseudo progression or something. So I think we could describe what happened in our cohort.
I have one more question, Dr. Che. This is like what we discussed before with Eugene and Jihyun about the modified RESIS that we use. So the new target lesions that you want to add on, before we only add on the new target lesions from the after treatment. So 2 months after post baseline, or we also insert the new target lesion from the baseline, because we have 3 timeline, like pre-baseline, baseline, and after treatment. We have some patients that have a new target lesions in the baseline, but we didn't add on in the total of the tumor burden, because we think that it's like the baseline only the target lesions, and the modified one we add on the new target lesion from the post baseline or after treatment.
I see what you mean. Eugene, do you understand?
yes, but I think I discussed it with you at the conference in Korea, and then you gave me an answer that we will only, the modification actually is only made for the post, you know, the 3rd time point, not the 2nd time point. Yes.
Okay, I agree with that, because before, like like we have like kind of different discussions about this, but I also agree if we only use the post baseline only for the third time point. I think that, thank you.
But it's a good question because I think you have to be consistent. If you
Mm,
think about consistency, because you have that 3 time point, pre-baseline, baseline,
mm,
treatment. What I said is that the resist rule is 2 per organ, right?
yes, at maximum
Yes, yes,
5.
yeah, it's true. Maximum 5 organ, 2 per organ.
Yeah, maximum 5 organ, 2 per organ. So that is kind of tricky because if you have new pop up, if you already counted 2 in the organ, let's say liver, you already have 2, and let's say 3 big ones popped up. What are you gonna do? You can't do much because of the restrictions.
Yes.
Mm.
So it becomes tricky. But if you think that's why resist criteria just says progression. If you have a new lesion, they don't even measure it. They say progression, new lesion. It's not target lesion.
Yes, I remember there's a mention that actually when you see very like likely new lesion
Uh-huh.
in the article describing resist 101, there is this thing you can consider that as a progression regardless of the number per organ, something like that.
Yeah,
So
yeah.
I think we
Not-
can.
So that's why resist calls it not target lesion. The new lesion is not target lesion.
Yeah. And they have the criteria for what you consider a new lesions. Like 5 millimeter is not new lesions. They not consider that as new lesions. They have the criteria for the measurement.
But the criteria is same as target lesion.
Yeah.
It's consistent.
I have another question, Dr. Che, actually, because you want to check about the pseudo hyperprogression for only the champion. We put like a timeline, right? For like maximum, like as an example, from baseline to after baseline or after treatment, we put maximum 2 months, 2 until 3 months. So for the pseudo hyperprogression or the next CT scan, how many months you want to put as the what you can as the
Time frame?
like as the time frame? I mean, like 1 year is cannot be considered for like pseudo hyperprogression. It's like too long. Or you want to put another 2 or 3 months again,
This one?
as long they are in the same regimen.
So the scan interval is going to be, what's standard? Usually 2 to 3 months.
Okay.
Nothing more than that. So the modified, I still think capturing new lesion is more accurate way, but how do you reconcile with the restrictions, their rules? I think one way is to not follow resist. We're not going to do resist. We're going to do resist for pre-baseline, but for the new lesions, we can say we will count them as target lesions, but it becomes tricky because let's say you have 5 new lesions across different organs. I think it may be going to be too much. And I'm thinking pre-baseline to baseline and the baseline to post-treatment, you may have to be consistent if you want to, apply this new rule. But so what did I tell you, Eugene, about the post-treatment? Did I say I will add all the new target lesions or?
Actually, I shared that as soon as you shared with me with Jian and Arnie. So
Yeah.
I'll pull up that note quickly.
Yeah.
'cause, just give me a sec.
It's tricky.
So yeah, I'll just read the brief note. So for the new definition, we are going to stick with original RECIST principles for
Mhm.
the target lesions in
Mhm.
terms of size and number criteria.
Okay.
But we modified to incorporate any new target lesion. The longest diameter of over 10 milliliter for lesion or the shortest diameter over 15
Mhm.
millimeter for lymph node. Still, we don't limit the number of new target lesions, which means if the number of total lesions, including the previous and the newly noticed target lesion is over 5, we still consider any newly spotted target lesions into our calculation.
So
Oh,
no restrictions.
For the number criteria,
so it
It's
means
not
that
it's not 5, it's actually 2, right?
um,
2 per organ.
2 per organ, maximum 5. I don't think we can only choose
it-
one.
for the resist, for the original one, 5 organ, 2 per organ. So it means total will be like 10 maximum, like if you count it. But I think
I
these
was
definitions, it means like there's no maximum number. Like it's we only count we take the diameter criteria like 10 and
Yeah.
15, but
As
we can
long
put
as
as much as we can, like maybe like if we can find like 15 lesions or more than like 6 target lesions, then we can add it on. Is that?
although that's unlikely, like we spot 15, but then yeah, that's still correct.
Yeah, okay.
I mean,
I think,
as long as that newly popped up lesions are meeting the criteria of the target lesion, the real target lesion, like
that
over
actually
10 milliliter.
it's kind of fun, because usually when I do before when I do the RECIST criteria for our patients, if I see there is new target lesions and I know because in RECIST it will be count as progressive disease, I only pick up the big new lesions. So I didn't there's a lot of new lesions, but because I know if there's new lesion will be progressive disease, I only choose the big one, like 2 or 3, the biggest one. But if with this criteria, it means that you can add on as much as you are from the picture, because it will be different. The tumor burden will be different, because if I use RECIST, I already know this is progressive because it's new lesions. It doesn't matter how many size that I have. I think you kind of get what I mean.
Yeah. So well, the thing that we learned is if we use that definition to count only the post new lesions into our total target lesion, it's not reflective of OS, worse OS, at least.
For Champia.
So it becomes an inferior marker, a prognostic marker. That we didn't know, that you found by doing this analysis.
Yes.
So I'm rethinking whether adding new lesion is a good suggestion or not. Just based on what we found.
Correct.
But I still think that a lot of hyperprogressions that we saw in clinic has to do with a lot of new lesions. And our current definition is not catching that.
That's true.
So I do think we need to still capture those. So let's go back to non-RECIST definitions. So we have response criteria by WHO. And it's 2-dimensional. The WHO criteria is 2-dimensional. And then I think it counts new lesions. Does it?
WHO.
Need to check first.
And WHO criteria has immune RC as well.
Oh, yeah. Actually, WHO doesn't have any limitation on the number of lesions in terms of calculating. This
Right.
is
And what about the new lesion? What's their criteria for new lesion?
For new lesions.
Uh-huh.
For the like size or
And how do they add that up, or do they say new lesion is just progression like resist?
oh they say for progression 25% in existent lesions of appearance of new lesions. Can I share what I've
Yeah.
Eugene, can you share the link or maybe the criteria?
yeah, I just found in Google, so let me. So here, can you see the comparison between WHO and RESIST?
Where's the new lesion?
So I just checked new, and then here for progression, I don't think they consider progression whenever they found new lesion, but they find new lesion, but I think they have some criteria for the size increasement.
I
No,
don't
I don't think.
I don't
Yeah,
understand
I don't.
of. Is it or?
Maybe this document is not that reliable, but can anyone find some more?
Wait. Overall response.
Oh, progression, 25% increase of one or more lesions or appearance. I think there should be.
I think, but I'm being honest, if it's like more than 25%, it's like less than the one in RESIS because RESIS is like 30%. Oh, I'm sorry, 20%. So it's like more than RESIS actually, like 20%. But I don't think like more than 20 millimeter because, yeah.
Because for WHO, they consider all the measurable, previously measurable and then new lesion without any number limitation. They consider the sum of the lesions as a whole, maybe like not specifying the portion of new lesion. That's my guess as of now.
Mhm.
Yeah, my guess is for WHO, they consider previously perceived target lesion and the new lesion as a whole, but for RESIST, they try to classify, differentiate them. So
Mhm.
for example, like
Mhm.
if you see here, they say or appearance of new lesion. So I think that we can say like that's the main difference between two measurements. How they treat new lesion.
Mhm.
And
How about eye resist? How do they treat eye resist?
in iris is how they treat new lesion.
Lesion, yeah. So irises, the new lesions are recorded separately in the case report form, but not included in the sum of the lesions for target lesion identified at baseline.
Oh, more like resist.
Yeah. Hmm. So iResist is something that is used for only patients receiving immunotherapy. I think they really gave some thought about what is the best way to deal with the new lesion. I think they have IR response criteria.
Yeah, they have the criteria for the IRSs. They have the response criteria. That's what I'm telling you about 2 time points. So that is like for the response. That's why they need another time point for the response. After the first time point after the treatment, they call it like just like probable, not like the direct diagnosis. Let me.
Immune-related response criteria. It's called immune-related response criteria. Immune-related response. It doesn't have anything about the new lesion here.
Can I share something I
Yeah.
found? Maybe you already have seen this, but here it's comparing RECIST 101 and then iRECIST. And then for new lesions, I noticed they use very interesting concept. So here, unconfirmed progression and confirmed progression.
Yeah.
Yes, so for I think as Dr. Arnie confirmed, for to confirm true progression based on the new lesion, they require another assessment, additional assessment. So any new lesion.
Actually, I opened the same page with you. You can go a little bit in the down forward. They have the graphic like showing see this one. So in this one, you can see like in the blue one, that's using the previous RECIST, but the red one is using the iRECIST criteria. So with the iRECIST, yeah, but so the difference is like how they describe the new lesions. For the iRECIST, it's still unconfirmed until two time point. That's why like the graphic will be different between iRECIST and RECIST 101. So yeah, I mean, if you want us to do the iResist also, we just do the modified, I think.
No, I don't mean to do iResist. It's really complicated. In the whole idea is the new lesion persistent or getting larger, then it's confirmed as a progression. If it's regressing, then it's pseudo progression. So it doesn't count as a progression. So that's the whole idea. But there's not iResist, but iResponse criteria, which is
Mm,
by WHO. So they made their own version of so they call it immune related response criteria. It's called IRRC. It's very different from iResist.
oh, okay.
And they still don't have no criteria for number of target lesions.
Mm,
Uh,
oh,
so my gut feeling is that having the limitation of 2 per organ is really not good to better assess the true tumor burden.
that's true.
But we make that new resist criteria, it's only for hyperprogressions, right, Dr. Che? It's only for counting hyperprogressions.
What did you say?
The new definition of the resist, we use it only for hyperprogressions, right? The one that we suggest, it's only specific for detecting hyperprogressions.
In our study.
Yes.
Uh, I may be wrong, but I think the ideal picture would be, so for the baseline and then, so at the second time and the third time, let's say we have 3 time points, pre-baseline, baseline, and post-treatment. For
Mhm.
the previously existing lesions, 2 time points were good enough to evaluate them. But for the new lesion that popped up and in the like 3rd time point in the post-treatment imaging,
Mhm.
I think the best way to deal with them are actually having another time point that would be the 4th time point
Mhm.
for us, like you suggested. I think that would be the ideal way for us to actually evaluate the new lesion, the meaning of new lesion, and then to figure out whether we can confidently say that as hyperprogression or not.
Yeah, I think that's vital. I think we have to take out pseudo progressors. So the only way to do it is have
Another
what
evaluation.
iResist did. So have 4th time point, and is the new lesion increasing? And iResist said, at least over 5 millimeter. That's what they said. So we can apply what iResist did, and say, because our goal is to say, is this true hyperprogression or pseudo progression? So to differentiate between the two, I think our modified criteria should say, let's look at what happened to the new lesion in the post-treatment number 2 scan. And if it grew, I think I'm fine with what iResist did, apply that principle of did the new lesion persist and grew by 5 millimeter or above, then you would assign that patient still in the resist hyperprogression category. But the
Yes.
thing is, the pseudo hyperprogression, they tend to regress, meaning the tumor get smaller. So that's going to be a little bit tricky. So I think we have to really give some thought about what's going on there. So that's number one. Number two is if we want to go measure new lesions, I think we should not limit the number, like the limitation number per organ, just like what response criteria did by WHO. So that's going to be really hard practically, like measure all the measurable lesions. But I still think that's the right way to do it. I don't necessarily think we have to do bidimensional like response criteria did. I think we can remain at with the RECIST criteria for target lesion measurement, but we can just do away with no limitation. I guess do away with limitation rule and just record and get the sum of all the measurable lesions. And then we can, and then for the baseline and post-treatment, apply the same rule of adding new lesion to the sum of the target lesion. I think come to think of it, I think that's being more consistent.
Oh,
If we want
Dr.
to follow the rule.
Dr. Che, it means it will be a good discussions. Also, I feel it means right now, if we only will do champion, so at this point we must check 2 CT scans, right? The CT scan after 3 months after after treatment, like for the pseudo hyperprogressions, and we need to recheck again the CT scan for the after treatment one, or the 2 months after baseline. It will be a great discussion, so we will know how much tumor burden that we can add without the RECIST criteria. Like if with the RECIST criteria, we get this kind of size of tumor burden, but if we didn't limit the number, then maybe we can get more size of the tumor burden. And I think it will be good comparison if we make it into table for after treatment. I mean, it's just like a suggestion for me, because I mean, like when I did the RECIST criteria, I didn't really consider many new target lesions. As long there is new target lesions, it's progressive. So I will only choose the big one. But if we need to count all the new target lesions, more than 10 and more than 15 for lymph node, it will be like a different summarize of tumor burden.
Yeah. So if you do the volumetric analysis, if you do the WHO criteria, it's everything measurable. So but it's a lot of work because we're gonna have to do, baseline and post-treatment, all measurable lesion. So it's actually opening up the whole image. I think it's going to be a lot of work if we choose to do that.
Why the baseline? We also need to count every lesions in the baseline. Why we didn't only choose target lesion for the baseline one?
To be consistent.
to be consistent. So it's
If-
pre-baseline. Pre-baseline, also, you have to be consistent. If I say I don't want any 2 per organ rule, I have to be consistent over 3 scans.
Mm.
Okay, so it
understand?
means, yeah, I understand. So it means right now it will be 4 scans if we want to check the pseudo hyperprogressions. But if we only use it for champion, I don't think like it will be a lot of work if it's only champion. But if you want me to check it for like 128 patients to recheck everything, it will be a different case. I think for champion, it's not a lot. If we want to just to recheck whether it's like pseudo hyperprogressions or not, but yeah.
So checking pseudo hyperprogression for Champiad definition, I think we can do it. It's only a few patients. But if we want to relax the RECIST definition,
Yes.
I
then
think we have to, record all sum of measurable lesions in all the scans that is available.
Yes.
Because that's a big work. I want to see what that brings up, but I am also cognizant of our time restraint and resources. So now I'm thinking I don't want to get there because it's too much work. We are not, I guess the whole idea is I still believe counting new lesion is valuable, but then you have to deal with the restriction of 2 per organ rule. And now I'm thinking, consistency also matters. I think the reviewers will bring that up.
Okay.
Then it's almost like proposing a whole new evaluation criteria, which is going to be in a whole different paper. It's going to be, what happens if we, so I guess for the purpose of this paper, I think we could still say, yes, so let me summarize this way. I'll just wrap up this discussion. Number 1, for Champiad, let's still track down to see if there is any pseudo hyperprogressor or not, okay? And to evaluate who is pseudo hyperprogression or not, I will use iRECIST criteria definition, okay? iRECIST, because you need definition to say who is pseudo hyperprogression or not. So that has to be in the results and discussion, because we want to take out the ones that are not true progression. It is rare for pseudo progressors to be in hyperprogressors. They could be in just regular progressors, not necessarily hyperprogressors. Okay, so I want you to discuss this in the discussion. That's number 1. Number 2, this is about whether adding new lesion in the sum of the measurable lesion is more appropriate in defining hyperprogression. I think it is. But what we did with just the post-treatment measurement shows that it is not very predictive or reflective or prognostic in terms of showing good association with PFS or OS. So I don't want to discuss that in this paper. It's going to be out of our scope and too much, because if we suggest adding new lesion in a sum of the measurable lesion, like I said, we are going to have to prove ourselves by being consistent and doing all the new measurement on all the scans in our patients. So I think that's going to be too much for our paper. I think if we want to do another paper, we can do, another paper just looking into what is the best definition in the matter of hyperprogression. I think it's too much for us to do. I think we can do it if we have unlimited people and resource. But I don't want to do it because just of the time. For academic purpose and out of curiosity, I really want to look how that changes the picture. And you guys are welcome to do it if you want to do it, but I can mentor you. But it's a strategic decision to say that for this project only, I don't think we should touch that. So what we can say is in the discussion, because my case report of medullary thyroid case was also showing a lot of new lesions. And we can describe that, let's say, for hyperprogressors, but we can describe what we see in our cohort. That we can do. We don't have to suggest exact definition of new hyperprogression, but we can say among the hyperprogressors that was defined by Champion, let's just stick with Champion, how many of them actually had new lesions on immunotherapy that popped up? We can describe that, and where were those new lesions, how many of them were there, and all that. We can describe that. Also, if we I think just like what we did, I know this is not consistent, but again, I don't want to go there. If we allow adding new lesions in the sum of the measurable lesions, then we can identify 7 more patients that can be defined, and these patients, and we can describe that these patients were new lesions in the bone. We can describe what actually happened to those patients, and also we can track them down to see if they had the next scan. We can say, well, in fact, some of the new lesion disappeared, so I want you to be just descriptive of what happened to both groups. Champion, I'm not going to use the term modified Champion because I'm not being consistent here. Because I just want to say, if you add new lesion by the Champion criteria and find any body with more than double the growth rate, then those are 7 more patients. And those patients were, these patients with, how many new lesions and where are they? You describe them and then say, out of them, we found, some of them were pseudoprogressors later on. So we might be overestimating the hyperprogressors if we do it this way, or something like that. So we can describe that in the result and discussion. So I'll summarize one more time because this is confusing. Number 1, we will track down what happened with the 4th scan and try to tease out if any potential pseudoprogressors. Number 2, we will still say if we add new lesion, measurable new lesion in our calculation in the post-treatment RECIST, then we will have this more number of patients included. But it wasn't necessarily predictive of better PFS, worsening PFS or OS. I think we just have to be transparent. And maybe these new lesions on the next scan, didn't grow or still grew. Who are they? We can describe them. I don't want to propose like a new definition, new modified, and give a clear definition of those. What I want to do is just describe, if we look at this way, what happens. And these hyperprogressors, did they also have new lesions or not? If we include new lesions, what happens? And is it a better way to detect hyperprogressors? Maybe not, or maybe, I don't know, based on what you find in these individual patients. So again, our goal is to be descriptive. What happened to our own patients? And I want to stick to Champiad, and I don't want to call it modified Champiad. I just want to say, if we add new lesion in the post-treatment scan, from the post-treatment scan, what happens? That's the best way we can describe this, by not doing, new evaluation on all scans. Is everyone clear?
Dr. Che, I only have one last question about the we evaluate the last CT scan for the pseudo hyperprogression. You told us you want us to do using the IRESIS criteria, right? But if we use the IRESIS criteria for the fourth CT scan and we use the RESIS 101 for the third CT scan or the after treatment, it will be different, because if we use IRESIS, then probably in the third CT scan we didn't say it progressive disease, we said unconfirmed progressive disease, or maybe unconfirmed like stable disease. So it will be different for the definition. So what do you think about it?
So I'm not gonna use IR-RECIST for the first 3 scans. I am not. I will. So the whole idea is, if it's pseudo progression, then the new lesion is going to disappear or get smaller. That's pseudo progression. But if it's true progression, it's going to grow. And IR-RECIST criteria says 5 millimeter or greater. So I'm only going to use that definition for the fourth scan. So I'm not going to use confirmed or unconfirmed. That's not, it's, IR will say if it's unconfirmed, it's unconfirmed until you get the fourth scan anyway.
Okay.
What I mean is, if it's not confirmed, then it's not true hyperprogression. So if the new lesion is not growing, there is a risk of this being pseudo progressor. So my plan is to, if you apply that IRESIST criteria, how many of them has potential to be in the category of pseudo progressor? Just identify them as I described.
Thank you, Dr. Che. And I think for closing the discussion, I think Jiyeon have some picture that wanted to show to you before we end it. Did you already show it to Dr. Che?
So
No,
before we
actually,
get there, I want to go through this article. This is Jed Wolchuk, and Jeffrey Weber. They're all they're medical oncologists who did a lot of the immunology trial. They believe that there's greater rationale for immune-related response criteria. So this is not RECIST. So overwhelming majority of patients with cancer who appear to progress after they begin immunotherapy will never respond. They will continue to progress just as quickly as they would with no treatment, and just as predicted by RECIST criteria that have long guided most trial evaluations and many treatment decisions. So Jeffrey Weber thinks this is about 4 to 5%. And there's delayed response. And they think that this is present in some patients. So IR resists how long to keep the trial patient on the particular treatment. So FDA allowed the use of IR response criteria. But they still like to use RECIST. So some oncologists like to use IR RECIST. So Dr. Weber says, I am more concerned about individual practitioners stopping treatments too early. The assumption that any lesion growth or new lesion signals the failure of one treatment and the need for another has been around for decades. The fundamental assumption of RECIST, any new lesion is progression. This assumption appeared fully justified until immunotherapy came along. Isn't it scary? Any new lesion or significant growth in 5 or fewer carefully tracked target lesions constitute the progression under RECIST. For IR RECIST, on the other hand, is more concerned with total tumor burden. It calls on investigators to track up to 15 lesions. And if the shrinkage of some lesion equals or exceeds growth elsewhere, even if that growth involves totally new lesions, IR response criteria report stable or responsive disease. So you see that the difference in philosophy, it doesn't matter if the new lesion popped up. It's the total burden that matters from the IR criteria. Even when aggregate tumor burden grows, IRRC does not conclude a patient has progressed unless the initial findings are confirmed by second assessment performed at least 4 weeks later. So this is what we do with IR RECIST 2. You need another confirmation post-treatment scan. We're not talking about IR RECIST, but regular RECIST does not need confirmation. So the current hyperprogression definition adapts this definition, RECIST. I'm trying to. So here they describe the pseudo-progression phenomena with Nivo, Ipi, Pembro, mostly in melanoma cases. That's why they're embracing IRRC. And then they developed iRECIST later on. So pseudoprogression tends to show up as growth in some lesions and shrinkage elsewhere. Growth elsewhere is almost always real progression. If you don't have any decent alternative treatment and the patient reports feeling great, then you might continue anyway, just on the very remote chance you have another liver guy. But usually it seems best to keep at it with mixed signs and discontinue if you see steady progression. So this is also an issue of heterogeneity. In real life, if you see one lesion shrink and the other lesion still growing, it's likely to be mixed response and the other lesion will likely continue to grow. Anyway, so I think the lesson is you don't want to stop too early, but then you don't want to continue to treat if it's not going to work. And how do you know? How do you see? If you want to have a confirmation scan, you have to keep the therapy. But how do you know that therapy is still benefiting the patient? How do you guess which is pseudo and which is hyperprogression? It's your clinical hunch. It's your gut feeling. And that's not science. Your gut feeling is not science. I mean, it's your philosophy, and every doctor will do it differently. So that's why it's called art. You know, I could say one thing and the other doctor will say different. So I can tell you, I think Dr. Chisang was there. I had an enteric type lung cancer, and other oncologists are saying, oh, this is GI cancer. Why is Dr. Che treating GI cancer? For me, I said this is enteric type lung cancer. I've seen it many times. So it's your clinical decision a lot of times. But why do we do research? Because I don't want this to be, oh, if you go to this doctor has different philosophy. You know, every surgeon thinks differently. Same thing, every oncologist thinks differently. And that should not be the case. We will create data to say, if you have these features, then go this path, go that path. Right now, how do you differentiate who's going to have pseudoprogression, who's going to have hyperprogression? We don't know. Now, the best research start with the best definition. If you start with wrong definition, you're going to get nowhere. So that's why we really want to have a good definition, but we're still in the woods. We cannot see the whole big picture. We cannot predict future with what we have. So every definition is flawed in its own way. But still, I think for our hyperprogression research, I think we'll go with what we have, and we're going to use Champion. And we're not going to use Pursue modified version because for all the practical reasons I said, we're just going to be descriptive. And we're gonna focus on, we know Champia definition is not perfect, but we're just gonna embrace it for the time being. And if that's the definition we're going to stick to, how do we best predict that hyperprogressor? How do we do that? Can we come up with a scoring system? Maybe Dr. Jisung can help us with the radiomics score. If we see these features in radiomics, let's worry about hyperprogressors. Let's try to stop this therapy as soon as possible. Maybe it has to be combination of, let's give 1 score if you're male. Let's give 1 score if you have poor PS. Let's give score 1 if you have poor radiomics features. And then you can have something like CHAD score. You can have a scoring system, and if you beat that score, let's never give immunotherapy only. Let's give chemo and immunotherapy together for these patients to prevent pseudo progression, hyperprogression. So that is the art of the clinical research. How do you come up with the predictors, and how would that change your clinical practice? So we have to see the end to get to the next level. So so Eugene and Arnie, you should discuss this. How do you predict, and how do you come up with the next prediction model, and how would that change our clinical practice? It would be the end point has to be, are you going to do immunotherapy alone? And are you going to, at least we proved, this came from the UNO's very first abstract. Chemoimmunotherapy prevents hyperprogression. And if you do immunotherapy only, there's always higher chance of hyperprogression. So that would be our clinical decision making. Which path are you going to go? And what are the risk factors that will make us decide either path, go to either path? Are you clear?
I think so, but
I think we clear, yeah, quite clear. Until today, we discussed a lot today, so I think we will have like kind of small discussion for this to kind of establish how we want to go in the future.
So I know I said a lot, but it might be confusing, but this is all recorded. So if you don't get what I say, just replay what I say. Now, Eugene, you can finish showing what all the tables you created.
okay, let me get back to my slide.
I cannot hear you.
Oh, you can't hear me? Can you hear me?
Yeah, now I can.
Okay, so based on what we just discussed, I think I don't need to show every single things that I produced up until now, because I try to make a Cox model for each modified, which we decided not to use for our paper.
Mm.
So what I just want to briefly show you is risk factor analysis. This is kind of a very simple ANOVA. I think there's a small new findings regarding metastasis burden. So in UNO's abstract, bone metastasis was associated with the hyperprogression, right? But for our data set, liver metastasis is shown to have correlation.
Why is
And
that?
because we update our data set newly. So maybe there were some errors. I mean, bone metastasis didn't show up as a factor that is correlated with hyperprogression for the newly updated data set, which is, but my guess is newly updated one is more reliable because, yeah. we checked all the, I think not me, but Jian and I think other lab members collected the data again.
Okay.
So, and we found liver metastasis was reflecting of the hyperprogression. I mean, not reflecting, but seems to have some correlation. And actually, the result was very consistent across all the definition, which is interesting. And in terms of what you just said, you mentioned that immunotherapy and then immunocombo regimen was appearing to have correlation with hyperprogression, but in our data set, regimen was appearing to have correlation with hyperprogression only when it is classified into this, like into 4 categories. And when I combine them into 2, using immuno only and immuno other, statistical significance disappeared, as you see here.
Hmm.
And for histology as well, I don't think we can say it as a very solid statistically meaningful result because there are so many subcategories. Yeah, only solid factor was liver metastasis. For Champia and Sarabuzid as well. Sarabuzid, there were
Wait,
bone
wait.
metastasis.
Go back to the regimen. So if you
Yeah,
have
regimen.
immuno and clinical trial drugs,
Only one patient. Yes, for it's categorized as 4. 2 patients. Sorry.
2 patients. So
Yeah.
maybe that made different.
I mean,
or I don't know.
I think for this p-value, we have, to discern what actually make this difference, we have to do post hoc analysis like Duncan or, comparing each group as a like post hoc analysis for ANOVA. But I didn't do that. But when I combined regimen into 2 or 3, all the statistical significance disappeared.
So immuno only. So I guess what about chemo containing regimen
Yes.
versus other?
Chemo containing and other. I can do that. Yes. I didn't do that, but yeah, I
Okay.
okay. So Champia, liver metastasis, and then Sarabuzid, bone metastasis and liver metastasis. And Ferrara also liver metastasis. I think for our data set, liver metastasis was the most stronger factor that appeared to have correlation with hyperprogression across
But
different
Can you
definitions.
find other literatures backing it up?
Yes, so I've read some articles that actually tumor burden as a whole can predict the can predict hyperprogression, the presence of hyperprogression, and then they reference some articles showing that tumor burden as specific as bone meta or liver meta, something like that. So I think I can easily back up our result.
What about our data? What about the total tumor burden?
Sorry, total tumor burden. Can you elaborate more on about total tumor burden? Like the sum of the lesion?
Uh-huh.
I mean, when I did TMB, this is a very old analysis result. I didn't include actual sum of the lesion into the risk factor analysis as you see here, these are all variables that I included. Line of treatment and other things. TMB, I included TMB, but TMB didn't appear to have any correlation. Maybe because of the small number of patients who have data. But you want me to include like extra some of the lesion into this table or?
Yes, at baseline.
Oh, yeah, I think I missed that. The baseline tumor burden.
Yes.
Do you want to use any specific criteria, classifying patients into two groups? Or you want it to be regarded as an extra number?
Both.
Like, okay.
Because you just said in the literature, tumor burden was predictive of hyperprogression, right?
Yes, but I think they use it as a conceptual meaning, not like suggesting any solid parameters. But they
But how?
they said they explained the tumor burden can be metastasis.
Number
That's what
of metastasis?
number and metastasis on each organ, like just the presence of the metastasis as well.
We can do that too.
Yeah, so I included number of metastasis as well. We've set the number, 3 as a criteria. So 0 means patients who have number of metastasis less than 3, and 1 means patients who have more than 3, 3 and above. Yes. But
Hmm.
that doesn't appear to have any statistical significance.
And this is at baseline, day 1 of treatment, correct?
Yes.
Okay. So tumor burden, I think we did this in our other papers. We can use, because we use RECIST for this, for progression definition, I think
Mhm.
use RECIST sum of target lesions.
At the baseline. Okay.
Yeah.
Okay, I will include that.
Okay, go ahead.
Okay, I think. Yes, this is pretty much. Oh. Yes, I think, yeah. This is end of my presentation regarding this hyperprogression project. Yeah.
Mm, Okay,
you for
I
this.
think you have it. Just make it presentable as a graph and table for the actual paper. So the
Okay.
risk factors, univariate, multivariate, and the graph. So we decide not to do the modified. And you can still do the graphs for each definition.
For two definition, like champion and subopposite, right?
All right, because you don't have
There are.
none of them are identified. Yeah, so you could do it for two definitions. But the risk factors, I don't think you have to do it for both. I think you could first see what are more predictive and what is the distribution of hyperprogressors by different definition. Show like a pie chart showing, or Venn diagram, like who belongs to what definition group. That kind of Venn diagram.
Yes, we did that earlier.
Yeah. And then for the risk factor analysis, just do the Champiad. I mean, we don't want to have too many.
Okay.
Risk factor analysis, just use Champiad, univariate, then multivariate. I think that should be enough.
Got it. Yes.
And the new lesion, same thing. Who among the, just use Champiad for that one too. For the Champiad progressors who had new lesions, and then also if you count new lesion as a measurable target lesion, post-treatment scan, what happens and who are they, and just try, maybe use Venn diagram or pie chart to show what happened to them in terms of new lesions.
Okay, I think I have to figure out the format of the extraction diagram and then pie chart, but yeah, let's give it a try.
Okay. Okay, now, anything else?
For cancer screening, we had a
Wait.
separate meeting yesterday.
Wait, before we finish the discussion about the hyperprogression, let Jion show Dr. Che about the picture that she made
Okay,
before we move it to the cancer screening.
okay.
Well, I think I just made a figure about to explain the new definition, but in this article, Dr. Che doesn't want to make a new definition. We just will describe it. So I think we don't need to use in this article, maybe later. If we can make another study, then we can make.
Okay, okay, yeah. Sorry for the confusion. I think the new definition is a daunting task.
Agree,
Work.
agree.
Okay, good. Okay, Eugene, what's
For
the other
cancer
part?
screening, I
Mhm.
will. So we had another separate meeting yesterday, and there's nothing to show you as of now much, but we all like agreed on what should be added and what should be adjusted. So we're doing that, and then hopefully for next week we will present the pretty much done like manuscript or the ready to submission version of the paper. That's all.
Okay,
Yes. I think I can move. Next. Yeah, I will just finish my portion like this for today.
so what is pending? Cancer instance?
Oh, yeah. For cancer incidence, meta has not yet been done. Sorry, like I have to do it for each different cancer type. Like we discussed earlier, we will only focus on eight or seven most prominent, like prevalent cancer type. We do have like the whole result, the result on the whole cancer, but we have to do a subgroup.
Mm,
And for cancer, the separate review, Dr. Jian gave us a really great feedback in very detailed feedback on our pretty ready-made the manuscript Dr. Cho and I worked on. So we're revising that.
what is that paper again?
Cancer, do you remember we separate our narrative review into two, right? We decided to keep the
Progression
transfusion.
and incidence separate, yeah.
Yes, progression one. We are revising it for submission. And the incidence one, we have to make all the figure and the results. Yeah, hopefully by next week I will bring some tangible results.
Hmm. Okay. So yeah, that's going to be sort of like a basis of what the literature showed until now. So based on that, this high risk group, what are we going to do differently? So one option is to do an annual screening for these patients to see if the cancer is coming back. Right? So we're thinking about doing, is it a Gallery test or is
Yes.
it Exact Science, Cancer-Seq assay? So we need to carry on this dialogue, is the company able to fund our study? So please follow up on that.
Okay.
I think there's a gardens. So who
Yes.
are these groups? Patient with history of cancer or patient, cancer incidents? Cancer incidents in what group?
Cancer incidence in patients who received blood transfusion.
Mm-hmm.
That's very like basic concept.
Yeah. So I think with this paper, how do we make impact? So if we believe in what we wrote, we do think it's a risk factor that they receive transfusion. And, it's going to be hard to prove, but we can still implement.
Mm,
So I think we should, carry on this conversation with the Brazilian group and
mm,
see where we are.
yes, I noticed they are asking about review and then other things frequently. So yeah.
Yeah. So I just want to emphasize that we're not doing this to publish. We're doing this
agree,
to
yeah.
actually change our practice. To change practice, people are going to ask for scientific rigor. Like, is it really true? Like, how do you know that blood transfusion is a risk factor for increased cancer risk? How do you know? Are you convinced? What does the data say? And what is your hypothesis? What we said is we wanted to prove to the world, but we said for practical reasons, it's going to take too much money for the sample size. So we let go. Now, I think we're going to leave it at that with our paper and say, well, still, let's screen these patients. They're going to draw blood anyway for blood transfusion. Let's at least once a year screen them for cancer and see what happens. Let's just create real world data. We're not going to compare that to any other group and show the difference between incidents, because to show that there's too many patients are needed.
Right. It would be very hard.
Right. But we're going to do it still. So let's still push forward. So Eugene and Liam, make sure you follow up on a weekly basis where things are and just push. Like, we want, where are you? And you want to have the meeting. I know the meeting's coming up, but always don't forget, like, if we don't push, things are not going to get anywhere. We have to ask them, where are we? Do we need another meeting, or what's the next step? How can we help? And if they said it's always good to know if we're at the dead end, like we can't move forward, there's no fun. We as a company decided not to pursue that project. Fine, then we can find another company. We can proceed. It's like, if we don't follow up, no one's going to follow up. So I want to stress the fact that it's not the paper we want to publish and pet our own CVs. That's not important. It's how do you change the real world practice? But more than that, you can't change it for worse. You have to have confidence in what you believe. So the cancer progression, cancer incident paper has to give you confidence as a writer. Like, am I making something up, or is this really the data that I believe in? Just looking at the Mi-Suk Lee and Seok-Ju Cho's data, I feel like it's real phenomenon. Okay, I don't think it's fake. Then how do you explain it? What did the Scandinavian data say? Is it so Mi-Suk really tried hard to get Taiwanese Scandinavian professors work together with us. But it was such a hard task that she had to move on to applying for residency and stuff. So, so showing that with another national cohort is a big, task. We tried to do it with our own Medicare data, and just to buy the data was so much money. So we gave it up.
Right.
So think about it, this is your own project. This is a true public health problem. So limit the amount of transfusion as much as possible is really the key. And it has to be a public message. But if we have way to actively detect cancer, then we should do it. So
Got it.
still consider this your own project, and carry it forward, Eugene and Liam, and give weekly updates on where we are.
Okay.
Okay. Okay. What
Yeah.
happened to Singmi's project?
It's me and we're working with Natera people. So they suggested us to make a very detailed swimmer plot for each one of our patients. So we sent them like encrypted patient data, and they're making the figure. And yeah, we're preparing our manuscript as well. So I can say that we're almost there, but we're kind of polishing our figure and all the things for publication. Yes, I showed them the swimmer plot that I made, but they suggested like make it more presentable. So
Okay.
with every detail, like many information. So
Okay. And what happened to Jui's paper?
oh, that's the one that I update you very first, the cancer screening. Cancer screening meta-analysis, right?
Uh-huh.
Yeah, we had a separate meeting yesterday with all members, and for me, like I'm trying to make figure and table, adding all the necessary legends and more explanation. For analysis part, we finished it analysis, but we're kind of trying to make a word count limitation, and then like citation management. Those are left. So hopefully we are trying to submit it within 2 weeks, and then waiting the result.
Okay. Make sure you show it to me next meeting,
Before
the
okay,
final
next-
version.
okay.
Yeah. So Liam and Eugene, and Jisang, you can help make a list of the project, who's submitting where to what journal and when, and what's the timeline. We need timeline, because I can't, it's like every time we ask, like, where is it? Well, it's gonna be done, and we need a deadline. We need to submit this here by when, and we need to stick to the deadline. I mean, we're not only so for things like abstract and meeting, like if you want to go, like you do whatever you can to stick to the deadline. But when it comes to the paper, we feel like, there's no deadline, and we just, we do more, and every week. I
Right.
feel like the paper was almost ready when Jui was here, and then still it's not ready, right? So I feel like we need a deadline for each other, and just say it out and try to, keep your words. as much as you
Mhm.
can. Okay. Anything else?
Yep. Actually, we have a like that Excel file, listing all the projects, but what we need is, I think, deadline and then track portion. So we will add that too.
Yeah, yeah. Let's get deadlines. Added.
Understood. Very understood. Yes.
Yeah.
Agree. Yes. Okay, so I will see you next week for this for the lab meeting.
Great. I know it's late. Is it midnight then?
Yes, just past a few minutes from midnight.
Yeah. Okay. Good job,
I will-
Eugene.
Thank you. Thank you for having me, and yeah, good luck with the rest of the lab meeting, everyone. Bye bye.
Hi. Okay, Arnie, do you have anything else to add?
No, I think it's okay. Today's discussion is really nice. I learned a lot about the, like the future of for my project with the hyper progressions. I hope that we can finish the manuscript soon. Like Gion and Eugene like such a great help with this manuscript. So I hope that we can finish this.
Yes, it's almost ready. It's almost done. So it's a moving target. So don't think there's only one way to write it. As you write, it's just, for you guys to learn. We can always, if you have a better idea, we should discuss it and revise it as such. And if it doesn't make sense, then it doesn't make sense. So
I feel like the trickiest part of this project actually, because this is like a great topic. Every people have like new idea, like many idea about this project. And even for the next project that you want us to sum up all the target lesions, I'm thinking then how we decide the progressive disease, how we decide the criteria of the progressive disease if we sum up all in the first. So it will be really nice discussions. And I
the
think
progression definition is same. 20% and 30% is same.
okay. Yeah. So
Yeah.
it's nice. It's
It's-
nice to like have this kind of discussion. Yeah, I hope that I can finish this paper like before I back there. We will see.
Hmm.
Thank you,
Okay,
Dr. Choi.
good. Thank you. Okay, Jion, do you have update?
Yes, I have an update of my CTD. Can you see my screen? Okay, then actually I asked before about the IRB documents, so you confirm that as a co-researcher, and I will get the signature by Liam, and then maybe after 21st meeting, we can confirm the company. And about the patient samples, actually, I just re-selected the samples just with the good samples to make a ctDNA. So it was 32 patients with the 110 samples, and was all based on the new protocol, which means the patient just gave us 10 milliliter of a whole blood sample. It could be 5 or 6 plasma. So if you don't mind, I can show you my Excel file. So this is the samples, and the patients were the 32, and Z means that we used the new protocol level. So it was all considered with a Z level. So I asked to my lab to prepare these samples. So if we finish the IRB, then I think we can just get the samples from our lab and we can send it to the company.
So why don't you make a slide that says the ones you have
Oh, yes.
for the plasma, if you have at least 5 cc's, how many samples do you have and how many patients are they? And for the ones you have 5 cc's of whole blood, it's going to be, let's say, 2 cc's of plasma. How many samples and how many patients?
That was at 70, almost 74 samples. But the problem was each patient, because we have several time points, 2 of the earlier ones based on the previous protocol, but after 2 time points was based on the new protocol. So I deleted all of those patients because it could not make a better research, those samples. So I just reselected the patients, which has really good quality of samples, not to fail after ctDNA research.
So if you limit to, so 10 cc's of whole blood,
Mhm.
how many samples in total you said?
110.
110.
Yes, and the number of patients was 32.
32. 32. And that includes neoadjuvant and adjuvant and metastatics, both? Or
No, just non-metastasis patients, because
Yeah.
metastasis sample is now collecting right now.
okay.
So these are all non-metastatic cancer, and I'm pretty sure maybe 90% of the patients had received the neoadjuvant chemotherapy,
Hmm.
and I just got several clinical data, but new patients, I don't have clinical data yet, but I will figure out. And based on their data, I found the neoadjuvant chemotherapy was almost done by PHT carbo. So based on your suggestion on previous lab meeting,
Mhm.
there could be almost 25 patients who had received the PHT carbo as a neoadjuvant chemotherapy. It is a very homogeneous group, so we can analyze about the ctDNA those patients.
Okay. Okay, why don't you make a table with like the schema,
Okay.
time points of where the
Okay.
blood was drawn, what regimen was given, just write out the regimen,
Okay.
you know, trastuzumab, pertuzumab, carbo, and is it Taxol? Or those
Taxotere.
Taxotere, yeah. Docetaxel, So what are the main points you have, and so like a schema, make a schema figure on slide, because when we do presentation to our biotech company, I think you need a nice PowerPoint to show what we have.
Yes, I have a question. Do you want to make each patient's time points, or just find the number of at each time point?
Just represent it, what the most common area.
Okay, yeah.
Yeah.
I will make brief present PPT file. Could it be?
Yeah, or 3 types. Well, neoadjuvant, adjuvant, Okay. Next, anything else? Anything else, Jian?
Not right now. That is
So
what
you've
I
been
would
helping
have.
with, you've been working with Eugene and Arnie?
Oh, yes, in the hyperprogression project. Actually, we were a little bit confused because of the definition of the hyperprogression. So actually, I made one of the figure to understand what means of a hyperprogression. But I think maybe in this article, we don't need to use these figures because it was just, I just
Yeah,
made it.
no, I like, you know, this is what I want to do, but, you know,
Not right now.
not right now. This is
Yeah, got it.
another paper. This is
Yes.
too many. Yeah, and I like this figure. This is what I want to do exactly.
Okay.
But it's just too much.
Yeah, I think so.
Yeah, good, thank you. The other thing is I talked to Jisang and I know Samuel is interested, so you know, we have a nice lung transplant case. And there's a case report that we wrote up. And you can get it from Liam. I think Liam has the copy.
Yeah.
So
You already
based
shared
on
to me.
that, yeah, after the literature review, there's a NEJM paper too about lung cancer case that got transplanted.
Okay.
So the discussion is who are the right group of patients and what happened to them after transplant. So that, and our case report is the only case report that used liquid biopsy to track down, is there still liquid ctDNA from the initial cancer? The answer for our patient is no. And Liam, what are we waiting for? The protocol, is everything done? What's pending?
So we are we're getting ready to submit to the next journal. It got rejected.
Why was it rejected?
I don't remember. It's in the notes that we have in a separate document.
Who's submitting it?
Eugene.
Eugene?
Mhm.
Do you know what journal?
I have to look it up. I'll get back to you.
Yeah, ask her and let's decide that soon. Forgot to- So there's so many papers like this, like I don't know where where it is and who's submitting it. We have to, I think we have a table, so just keep track of it. So that paper has to go out first, and then I think you, Chisang, and Samuel can work on a paper.
Okay.
Now, there's another project. So Liam, did you hear back from Tempus whether they approved our mucinous adenocarcinoma project?
No, not yet.
Can you follow up, email them and ask them where we are? And then you can CC Eugene, Chisang, and Jion. Because if they approve it, what's going to happen next is we will get RNA-seq and DNA sequencing data of these bronchoalveolar pattern spread versus the other from all their Tempus data. It's going to be a lot of data. So I want both of you, Chisang and Jion, to analyze the difference between the two. So it will be more like creating heat map for RNA-seq. You know, what is the DNA or gene expression profile, GEP analysis Uh, so the question is, why are they different? Why does one lung cancer spread through lymphatic and bloodstream? And why does one lung cancer spread only through airway, bronchoalveolar? So that's the question. And how is it different biologically by DNA and RNA analysis? And if we know their unique signature, then the ultimate clinical application will be that if you have this signature, then please consider lung transplant upfront. No one has done this work, so I think this is important.
Okay.
So Liam, just follow that up, and if they approve, but in the meantime, I think that the proposal we sent them, you can share with Jisang and Jian, Tempest proposal. So that will be another project you two can do together. But keep on reading, and so that you know the details of the project. Okay, Jisang, any update on what you did?
Now I'm doing on radio mix. So I just wanna share how to do it. I'm sorry. So I want to share my screen. So let me authorize this computer to share the screen. All right, so can you see my screen here? Right, I just put the name Radio Mix 101, so I just want to share the basics of Radio Mix. And
Dr. Che, I think this is for the journal club. Do you want to do this now or later?
Oh, this is Journal Club?
so if you allowed me to just share what I'm doing and what about radio mix shortly, then I'm gonna do that.
Yeah, you can show us what you're doing. Yeah.
All right, okay. Mm, all right, so I want to give you a short presentation about radio mix and also get an idea from this, so you can use radio mix for your own studies. And then I also want to get your opinion about this, so you can add anything for this slide. All right, so radio mix is about extraction, texture and shape, heterogeneity of tumor by using some program. So we are now using LifeX, so that has a function to extract textures and shape like that. And so medical images, have valuable information, but it was overlooked, or we could not identify the information in the past. So now using this program, we can pull out biologic and prognostic information within image. So we can integrate and analyze with this radio mix with clinical and pathologic and genomics data to finally improve precision medicine. So just I'm gonna do now segmentation step. So first we obtain images from CT, or we are using CT scan now, but also we can use PET-CT and MRI scan. And then I'm on now on segmentation stage. So define tumor ROI, region of interest. So it's like drawing through the program by the margin of tumor and so peritumor region. So we call it segmentation. And then extraction morphology, like shape, physical characteristics, and texture. So based on pixel neighborhood information. And then we're gonna do the selection and the performance test after we finish segmentation. So so I don't know about these performance tests yet, but there are some random forest or principal component analysis, a lot of methods we can use. And so for the application of this RadioMix to our study, so first, there are many applications we can use. So I can briefly explain about this. So first, we may help distinguish between benign and malignant nodules. So that means pulmonary nodule evaluation. And then we also get prognosis information from this radio mix. So it's so there is prognostic and biologic information in routinely acquired CT scans, like tumor microenvironment in terms of behavior and progression. So we can predict survival for patients with non-small cell lung cancer. Yeah, some studies showed already, and about tumor hypoxia, angiogenesis, and aggressiveness, like that. And also, we can predict, at number 3, we can predict, it's not about cancer, but predict lung function, so pre-op or post-op, and disease severity, and GGO pattern, reticular opacity, honeycomb, like that. And also, we can use this radiomic for analyzing lymph node metastasis. So traditionally, the evaluation of lymph node metastasis was based on morphological change in CT scan or metabolic uptake in PET scan, but radiomix analysis first, the radiomix analysis of the primary tumor helps predict lymph node metastasis in lung cancer patient. So yeah, accuracy for predicting lymph node metastasis was 91%, about 91%. And then in few studies, features of lymph nodes itself identified the difference between malignant and benign. So it's also helpful to analyze about metastatic information. And the last, so some study also showed the results with genomics. So some CT features is relevant to genetic mutations like EGFR, ALK, and KRAS. So recent study presented radiogenomic map of non-small cell lung cancer, and it linked image phenotypes with RNA signatures. So according to the study, EGFR pathway was significantly associated with GGO and irregular nodules or nodules with poorly defined margin. All right, so that was the brief explanation of radiomix and its use.
Are you done?
So yes.
So how accurate is the radiogenomics?
Let me see. So
Do you have a manuscript?
I can find now. So
So another thing is, based on all these papers out there, especially the ones that are like the 1, 2, like a 2 and 5. Would any of them have any open source, like the algorithm? Or share program for us to use and see if their program is reliable or not. So that's one thing we could do. But we will also, we want to see what the performance is, looking at the GG, like the spread pattern. Can we, what is the certainty that you could say this tumor probably has EGFR mutation or not? So I think that needs to be sort of assessed. So this is
All right.
this is good learning for you and for many undergrad students. So I think this is useful. But for future, I think for journal club, try to find one journal that is relevant for your research, and show us the journal, and make it like 5-minute presentation of what they actually found and how did they do it in methodology, and what are the things that we can learn from this, things like that. Because this is pretty broad. I mean, this is okay for learning, but
All right.
yeah. Because I'm still skeptical. Like, you look at the image, how do you know this patient has EGFR or not, KRAS or not?
All right. I'm looking for more.
Okay. Anything else, Jisan?
That's all for
Okay.
now.
Okay. Okay, Ximyong, do you have any updates? Can you tell me what you've been doing in the lab?
Well, I don't really have like much, but I've just been managing the Pacemaker's Instagram account and updating the website. And I've also been doing the radiomics segmentations with, yeah. And that's like the main things that I'm doing.
Okay. Do you have interview scheduled?
Yeah, I have an interview with Dr. Jin Young today at 2 p.m. And then I also texted the patient that you were talking about, and she said she would be interested in interviewing in next Friday.
Are you available?
Yeah, if it's after 1 p.m.
Okay. But
But
what
she
time?
hasn't responded yet. I asked her what time she wanted to, but she hasn't responded yet. So I think I'll send her like a follow-up.
So you can look at my Friday schedule and see what time she's coming in.
Mm-hmm.
And if she's gonna get infusion for a couple hours, so she'll be there for sure. So that would be the great time.
Okay.
And if you can't do it, have Tim or somebody else do it, because like I said,
Yeah.
if we don't do it by next Friday, I don't know what her course of disease is going to look like. I think we will lose if we don't do it. So don't delay it more than next Friday, okay?
Okay.
Okay. Yeah, good job on your Instagram. And I think, Liam, our goal is to have nice photo for all the people we interview and the quotes. So I haven't seen them come up in Instagram, but that's our goal. We want each interview to sort of have nice picture. And I think, who said? I think Chui said there's like a New Yorker Instagram, like New York people figure picture and their quotes. So we want to do that for our pacemakers account.
Should we do that for like the past interviews too?
Yeah,
I think I only started taking pictures like for Lauren Beer's interview, and that post is coming up on Friday.
okay. So yes, the answer is yes. We could do it from the because you can do screen capture.
Okay.
Yeah, screen capture and do quotes. So I think we can utilize what we have. So yeah, keep doing what
Okay.
you're doing. Good job.
Thank you.
Timothy, same thing. Tell us what you've been doing and yeah.
Yeah, I mean, I think it's very similar to what everyone, or like Young and Dr. Chisang were saying about radiomics. Just been like segmenting and getting those done one by one. And then also, I think for Lunit, we got more information about the clinical data they wanted. And so I think Dr. Liam has been like talking with Dr. Easer about some like specifics about the type of data, or specific about timing of the data and like clarifying what each thing means basically. So we've been working on that as well. And then I also, have been working on the songs separately. So we're just waiting for more people to give recordings. So I think that's getting done as well slowly. I posted Rachel's version as well. I don't know if you saw that one. Yeah. And yeah, I think that's mostly it. Mhm. And we talked about the Joseph Busto also already. So working on that as well.
I texted Joseph Busso yesterday through KakaoTalk because Rachel Kim had his KakaoTalk. And I don't think he's reading it. Maybe this was working when he was in Korea.
Mm,
He didn't read it, so I'm assuming that he's not using the same account. So,
I see. That's possible. Yeah.
I was close, but
Mhm.
yeah, let's I want to invite him for not only for our GBM, but maybe for GMA. Yeah, so that would be good. Okay, so as far as the project is concerned, you're doing the radiomics. You're helping who?
Lunit.
Lunit project.
Yeah, AI pathogenomics, I think.
So who's writing that with you?
I don't think we're writing anything. We're just collecting data for them because they requested some information.
So I think they are writing it then,
Mhm.
the Lunit. So Liam, why don't you email them like with the data we sent them, ask them what what's their project looking like how is our data incorporated into what analysis, and we just want to have updates on what they did with our data and see. So send that email, CC me. I want to see what they're doing. Same thing with Natera. We gave them the discordant data and asked them what they have done with our data. And CC me where that is.
So with Natera, we have a follow-up teleconference coming up.
Okay. And is that to discuss that data or everything?
So, yeah, everything.
Okay. Anything else, Tim, that you've been helping with?
Oh yeah, pacemakers editing as well. I think I just got some stuff from Liam, Dr. Liam as well. So I think I'll be working on that.
Yes, I know Sally's and is Grace involved in that too? Where are you with the pacemakers abstracts writing?
The manuscript we're writing we're writing it with Sally, Sally, Grace, and Eileen. Our next meeting is coming up this Friday.
So you guys are writing it together.
Yes.
Okay. And the video, who are you interviewing, Tim?
So I don't think I got an interview for this one. I think Dr. Eugene and Sue interviewed this person. Let me check real quick.
Who did you interview so far?
Oh, Dr. Lauren Beret. I
Lauren
think.
Beer? You
Yeah,
interviewed-
Beer, sorry.
Okay.
And then, oh yeah, that's right. Dr. Liam told me to for Dr. William Bay.
Who?
William Bay.
Oh, William Bay. Yeah, yeah, yeah.
Mhm.
We need one for Marky Meminger.
Yeah. So
Awesome.
Tebin is reaching out to her.
Sabin? Okay.
Yeah.
Yeah, she's gone next week. So
Mhm.
after next week. So we really want to get hold of her before she resigns.
So Sebin was telling me that she was having a hard time getting a hold of Marky.
She has her phone number.
Yes.
Just keep reaching out to her a daily basis. Get me in the group chat so that I can enforce.
Okay.
I know she's busy, but she has time to interview. And then we talked about Sarah, our neighbor here. If you can interview her, I think she'll do it. Okay, anything else, Tim?
I think that's everything.
Okay, good. So what's your plan, both of you, Cecilia and Tim, after the school starts? What are your plans?
I think for me, mine is to come in weekly on Mondays.
Okay. Do you have school on Monday?
Yeah, but my class is at 4, I believe. So I'll be here at 8 until I have to go to class.
Okay, that's good. What about you, Cecilia?
I was gonna ask if I could do the research for credit thing. I can come in every week for Fridays from 1 to 5, but then for the other like 4-hour shift, I can't, like, I have lab on Monday and Thursday, like for classes, and then I have a midterm every Tuesday and Wednesday. But then the midterm that's on Wednesdays is only every other week. So I was wondering if I could like come just like from 12 until 5 on Wednesdays that aren't my midterms.
So Liam, what's been our rule for the people who take it for credit?
Yeah, so the rule was 1 full day of clinic, 1 full day physically in lab. So Tim, so I've discussed this with both Tim and Cecilia. Tim is going to be doing full day on Mondays. Cecilia is going to split her days between Wednesdays and Fridays, except Wednesday she's coming in every other week because she has an exam the alternating weeks. So we've discussed that she's going to do like 0.75 shift, you know how like 1 full day. So she's going to do half days on Fridays every week and then 0.75 days on the weeks that she come in on Wednesdays. So that'll average out to 1 full day for each week.
Okay, and whenever you're here, you could do research, but if you want to still be exposed to clinic for a few hours while you're here, you could still do that too.
Okay, yeah, I was wondering if I could do like research on the Wednesdays that I come and then participate in clinic on Friday afternoon.
Yeah, but I mean, it's good to be in clinic. I think there's a lot you learn in clinic. So I encourage that, but I generally want it to be like additional time. Clinic,
Okay.
clinic is not research time.
Okay.
For credit. Um, um, but if it's not for credit, I don't care. You could come anytime you want. But for I guess, but still, I guess my stance is if you still want to come while you're here in the lab, you could still join me in the lab, in clinic. But do your best to see if you can, spare more time for clinic additionally. But if you
Okay.
can, you can. I understand that.
Sounds good.
Okay, Liam, any other updates? I know we had discussed a few projects before, but
Yeah, so just a couple of things. Oh, let me just share my screen real. Yeah, just a couple of things over Zoom right now. When is your next meeting, Dr. Che? Don't you have interviews today?
yeah, when is it? It shows 11:30.
Okay.
And then I have lunch meeting.
With
And-
BMS.
And then another candidate did 2:00. And then Jansen, 3:00. Cancer screening project meeting. Is this with? This is with Gardent. That's 3:30, and Lucens is 4:00.
But then you can't do 4, can you?
I have to leave like.
So we had emailed Lucents yesterday saying we have to reschedule. So one of the questions they were asking was, they were asking if you were going to be at the NACLC.
Yes.
And they were asking if they just wanted to meet there instead.
Yes, we can do that.
Okay. All right, so we'll postpone the 4 p.m. with Lucents to during NACLC.
Yeah.
Okay.
Okay, let's do that then.
And then I'm just going to share my screen for a couple more things. So this is from Zach Lilly. We had emailed them before you left for Korea. And we were asking about the blood samples that they collected for the ramucirumab versus plus docetaxel trial. And we were asking them about the potential for like considering the biomarker study proposal. So the question was, this is what they said. I can now definitely say that there is not any whole blood available, but there is at least one aliquot of DNA from whole blood that is available for quite a few patients above 1,000. Would extracted DNA be sufficient for the study you wanted to conduct, or do you need whole blood specifically?
So we're looking at proteomic marker from plasma. So DNA is not going to be helpful.
Okay.
We need plasma or serum. Maybe you can ask again. We don't need DNA. We need serum or plasma. Less than 1 cc, just very small amount is fine. Can you just ask, confirm that whether they have it or not. Yeah.
Okay,
And CC me. Yeah.
will do. And then this was an email from Megan regarding the thyroid paper.
I can't show their extended progression without better data. Your data in Rave is terrible, and the fact that you can't even see it in the Rave makes it even harder to justify ignoring. Their data is truly unacceptable, and the fact that they won't take any effort to modify the data to match their clinical is pretty disconcerting. Honestly, I have never had this issue on any of the other trials. I have never had to have a sign off on publishing data so far, but it's provided in Rave. So SWOT rule states you have to complete SE eval before publication. So that will hold up publication if you can't get this. Paper draft was pretty hard to follow. I'm not sure I caught all the comments. I did my best to update, but I would really like to go over the next version. So okay, so this is very complicated. Okay, just say, okay, I will respond to her. This is too complicated. I'll call the study this. So Liam, thank you for following up. It's just so complicated. This is what this is how difficult clinical trial is. And managing its site is so difficult. Okay, next.
Okay, and then just one more thing for the meeting today regarding regarding the J&J proposal.
Uh-huh.
There was a couple of places, couple of like points that they wanted us to fill in on.
Okay.
So just give me a moment. Let me just pull that up here. Yeah, so for some reason your ID and password for that portal expired, so they just sent us an email with like a paper submission workbook. So that's what we're working with right now. And this is what it looks like. Let me just zoom in a little.
Okay.
So just a couple things to just double check with you, and then a couple of like sections that we need to address. So the study type is interventional, right?
Yeah.
Okay. And then study design is parallel, it's non-randomized. The
Yeah.
primary goals, so I chose efficacy, outcomes research, and biomarker study. Was there anything else you wanted to specify?
No.
So one of the sections that was important for us to address was the duration of the study. We didn't address this at all.
Total study duration. Okay, final protocol to IRB approval. 4 months. Approval to first patient. 1 month. First patient, first visit to last patient, first visit. 24 months. Treatment period would be 6 months. Long-term follow-up period would be 24 months. Interim analysis, PPS, not applicable. Final reporting time after last patient. 6 months. Publication submission time after final study report. 3 months. Okay.
They also asked for method of collection and time points to assess outcome.
So objective response is evaluated by RECIST 1.1. And the time points would be the baseline and on treatment CT scan at 6 to 9, and with 6 to 12 weeks of, well, in our protocol, did we say 8 weeks? Well, you can say 8 weeks. 8 weeks plus minus 2 weeks. A week at a week time point, and you can put plus minus 2 weeks.
Okay, so just those 2 time points. Study population, we're only looking at adults, I assume. The age and years, I just arbitrarily put 18 and 80. Did you want to make that different?
Maximum, you don't need any cutoff.
Oh, okay.
Not applicable.
Minimum 18 is okay.
Yeah.
Okay, and then they were also asking for statistical power calculations. Did you have any input on that?
I would say I don't did we put anything in our proposal about
No,
no?
no.
Say only descriptive statistics. And open the hypothesis generating trial. Yeah.
And then for type of support that is being requested,
Drug.
and then are there any institutional requirements?
Yes.
Is this also yes?
Contract to be executed. Say unknown.
Okay, I think that's it for this one. We can finish up the rest and then send it out.
And when is the meeting with them?
With Janssen,
Uh-huh.
I'll have to check. To discuss this protocol?
Yeah.
I don't think we set up a meeting yet. Would you like to? Because the next step was to submit this proposal to their portal and then it'll be under their review. And then they'll get back to us.
So submit to portal and also the copy of that to Arun and make
Uh-huh.
sure he doesn't have any questions based on what we submit.
Okay.
I think he gave us a deadline.
So it wasn't a hard deadline. He was just like sooner the better.
Okay. Just check to see if I think there was a ballpark deadline by calendar date.
Mhm.
So ask him if we're still okay or what, and then if he's okay with the contents.
Okay.
But regardless, still submit.
Right.
And CC me.
Okay.
Okay, very good. Anything else?
No, that's it for now. I think there's gonna be a couple more things that come up later in the week. I'll just bring that up to you separately.
Okay, very good. So we'll wrap up here for today, and I'm here for any, questions that come up. Please reach out to me. Because today and tomorrow is my research day, so I'll be able to help. Okay, talk to you guys later.
Thank you, Dr. Chen.
Thank you.
Thank you.
Recording.
Mm.